Hey everyone, we all made it through another week. My name is Yasi. I've been with Endocare for the past 5 years.
And I'm Nikki. I've also been with Endocare for the past 5 years.
We hope that you guys are having a smooth transition from pre-COVID practice to, I was calling it post-COVID. She reminded me we're actually in mid-COVID time. I'm gonna share my screen here with you, and we're gonna go over our presentation here, which is the innovative technologies used in modern endodontics. Basically, we're gonna share a few of our cases and how we incorporate the new technologies in our day-to-day practice to present a more efficient, successful, and predictable treatment for our patients. For those of you who don't know, I'm originally from Iran, and I became an endodontist the first time in 2001. And then I moved to US in 2007 and did another 2 years of dental school and another 3 years of endo residency at UCSF. The question I got a lot during this time was, don't you get bored doing it over and over again? Part of it actually has to do with the fact that we really enjoy what we do on a daily basis, but the decade between the first time I graduated and practiced and then the second time that I graduated and now I'm practicing was the golden time that a lot of basic science, and on top of that, actually a lot of innovation and technology was introduced in our field. And me, as a practitioner from a decade ago and now doing it again, I can really attest to how much our field has changed. Okay, so our mission statement and our philosophy in Endocare is not only to create an environment with compassionate and comfort to our patient, but to use the latest technological advancement in treating our patients. We would both like to extend a big thank you to all the doctors in our practice, because we're going to share the cases you see here are mostly done in the past few months in our practice. We were just not going to caption every single one. Also, I've included a few cases of Dr. Lee and Dr. Salman, who were my residents at University of Pacific and are now our fellow endodontists in Southern California and Colorado. So what really changed in the past decade? I think the most important one, or the most significant one in this game-changing thing, was the microscope itself. More and more, I know the general dentists also who are appreciating their loops. Really, the magnification and the illumination changes the way that we see things and our field of vision. I know a lot of you might be even using microscope in doing your restorative treatments. We have our favorite microscope here and there in different offices. We have both global and Zeiss microscope. And my favorite one is a ProErgo, which is an automated microscope that we have in Walnut Creek office. And I always say I'll change it with any Maserati at any time. It's really an amazing thing to have. The next thing that really changed the game for us was the CT scan. I mean, to have the opportunity to see the 3D in real time, it's just the value of that. We have patients who come to our office, and unfortunately CT at this point is still not covered with insurances. So you get a lot of these questions of why do we need to take a CT, and if it's that necessary, why isn't the insurance covering for it? I always like to take the CT and then go over it with the patient so they can see the details and the real-time 3D that we see in that CT and the valuable information that we acquire from the CT scan. And honestly, I always tell them, if at the time people starting doing root canal treatment, the science had caught up, nobody would have been okay with just having a two-dimensional radiograph. The next thing are the files. I mean, I actually lost track of how many new files we've had in the past decades. And for the longest time, my philosophy was, if a file works in your hand and you get consistent shape and you don't separate them, why do you even want to change and try a new one? Except it's been the paradigm shift even in the philosophy of the way we shape the canals to keep it more conservative with less tapered. And the methodology of the new files really has offered us that luxury that we can do that efficiently. And then people who know me, they know that for the past 5-6 years, I'm tired of the new files. This is supposed to be a chemomechanical debridement. I think we have honed the mechanical part of it. It's time to get a better chemical than hypochlorite. We've been using it for 50 years. We need to come up with a new way of chemical debridement. And although ultrasonic really created a lot of advancement, but Endo or GentleWave was the thing that was the game changer, at least in our practice. It's been around for 5 or 6 years. We have had it in our offices for about 8 months, I think. And Nikki is gonna go extensively over how we are incorporating this technology and some cases of it. So as we talk about advancement, the future is going to bring something I'm interested in, which is the dynamic navigation, which is going to combine the 3D CT with the instrument and the handpiece that you're doing your access with and you're going to start your root canal with. And theoretically, it's really going to be helpful and accurate in locating the calcified canal and helping us have that conservative look that we all want. There's been a very interesting webinar about it that Dr. Salman has had, but it's not quite there yet. As the margin of error of the accuracy of that is about 1 millimeter, which in an access cavity is actually a significant amount. So far, this technology has been successfully used for implant placement, for guided apical surgery, but for root canal treatment, I think we still have a little way to go with it. This is Dr. Tran pre-COVID in our Pinola office. And that's basically how we do our treatment. We have the microscope through which we have a camera attachment that real time you can see what he sees through the microscope, or the patient can see. We have the photograph there, and on the other monitor, we have the CT scan and different cross sections there. This is another view. These are typically the photos that we can see through the magnification and with the illumination of our microscope. The end result of incorporating all of these technology, of course, beautiful, prettier, curvier canals to send on reports to your office. But as a part of our philosophy, we also do care a lot about having a patient-centered outcome, meaning having patients who are happier, less in pain, the treatment is done more efficiently and quicker on them. This is also another step that we always have in mind, which is you deal with a mineralized tooth like this. It's important not only to find the canal, but to do it in the most conservative way possible. And really the microscope and the CT is what provides us that opportunity to do a root canal like this and keep the integrity of the tooth. So from this point on, I'm just gonna present some random interesting cases, like I said, that we've mostly seen in the past few months in our offices. This is a case of Nikki, actually. We called it the Valentine tooth because it happened on Valentine's Day too. It came from an orthodontic practice to our office, and you probably don't see it very well here on the panel, but there was a lucency on the panel. On the PA, you can appreciate how the shape of a canal is a little unusual. And I think on the clinical exam, they also had a catch on the coronal portion of the tooth. Here's the video of the CT scan we took. So look at the upper right, that's the 3D rendering, you can see that evagination on the coronal portion. But this is the most interesting view for me. That's the coronal view. I'm going up on the upper left. That's the axial view. You see how the tooth evaginate internally. The interesting thing about this tooth is when she tested it, the tooth was vital. And what they were looking at, this lucency, was basically the nasopalatal duct. So I think in this one, we got lucky the tooth didn't need treatment, because with this interesting anatomy, it would have been quite a day. So as you see again here, on the two-dimensional radiograph, and this is just a snapshot, but you can see how this lucency can be mistaken by an apical lesion, but in reality, it's just a superimposition of this nasal duct on the apical portion of the tooth. This is another case. It's actually another Valentine's Day case. Dr. Milan had it really like a heart-shaped thing here. This also came to our office from a general dentist office. And a different view, it looked more like an apical lesion here. On the coronal or frontal view of the CT, you can see that the PDL is consistent and you actually don't really see any lucency there. On this cross section, you can see the nasopalatal duct looks a little bigger and a little unusual shape there. I think she measured it at about 10 millimeter, and then you can see how it's been like really invading into the bone space. This case was sent to oral surgeons and came back as a nasopalatal duct cyst. Here is an interesting anatomy case. The patient came in with palatal swelling. On the PA, you can see the lucency here, pretty diffused. You can see the curvature. On clinical testing, number 2 was testing normal to cold. Number 3 did not respond. So the diagnosis was that number 3 is necrotic. Here's the 3D rendering. You can appreciate the curvature on that mesiobuccal root there. And then looking at it from the palatal side, you can see the destruction of the bone, how extensive that is. On an axial view, you appreciate the anatomy of how these roots are fused and the anastomosis between the distal buccal and the palatal. And you can also see that the lesion is more centered on number 3, although it kind of extends towards number 2. You can also see the thickening of the sinus in this view here. This is the sagittal view, which looks more like what you see on a two-dimensional radiograph here. This tooth happened to have 5 canals in it. And I think you probably can see some of them here. Nope, here's the final. Next one is this case. This is actually Dr. Tran's case. And as I was preparing this presentation last night, I called him and I asked, Dan, why did you take a pre-op CT scan on this one? Because to me, initially when you look at it, it looks like it's a normal root canal on number 14 through a crown. And he's like, well, I think the mesial canal was kind of fading on the apical portion. I was looking and thinking, oh, is it fuzzy here? Could that be some external resorption? But good thing is that he did a pre-op CT scan on this case anyways, because this is what we were dealing with. This is the horizontal cross-section, the axial view, and you can see 6 different canals in this case. Here are the MB1, MB2, MB3, and then the 2 DBs and the palatal, which are kind of like a C shape. This is after they've been shaped and prepped. On a different view, you can see really how beautiful. I mean, Nikki is gonna show some micro CT of these cases too, but you can really see how beautiful these anastomosis are. And although at the end they all come to a common part of exit, it's just the finesse of preparing these canals, which is the fun part of what we do. And of course, this is the obturation, they all come together. So have you not had seen the CT scan, you probably wouldn't know how difficult it was to finish this root canal. This is another premolar, and I always have this dilemma. I don't know what you think. To me, I can't decide which one I like least, the lower premolar or the lower anteriors. But obviously, when you see a case like this with something, we call it a fast break, when the canal fades is when you know you need to take a CT, and when you know there's going to be a deep split on this tooth. Sure enough, that's where the split is, and this is how the case was completed. Another lower premolar with interesting anatomy. Let me see what this is. Oh, this is the video of that. We can skip this one. Do you know how I can skip it? Oh, here we go. Okay. This is, well, obviously I like lower premolars better because there is more of those cases. This was a very interesting case. It's an emergency 60-year-old gentleman. He's a physician. He walked into my office very distressed with buccal swelling and paresthesia on the lower left side. He has had a mandibular advancement surgery before, so not only he was in pain and agony of the emergency situation, he had his concern if he's gonna lose the tooth, if the surgery has got infected. So we took this PA, and you see that lateral lucency there, and then you can always see the plate there too. On the CT scan, you can see where the plate is placed, and then you can see the mental foramen. This is actually one part that really CT helps with the safety of how we render our treatments, because when there are vital anatomies, sinus, IA, mental foramen, we want to really know that beforehand based on our CT, because we're going to change and modify the way we treat these cases. So if you look here, you can see the IA running here. And then somewhere around here, you lose where the mental foramen and the lesion, they all kind of merge together. And of course, in this one, mainly the lesion is lateral on the tooth. On this view, the tooth is literally sitting on mental foramen. We see this often in the lower premolars when there is an acute abscess. Because of a pressure, you can get some paresthesia in the area. So what I chose was, as much as I like GentleWave, to not use GentleWave in this case. And also I used bioceramic material. And I stayed a millimeter short in my final prep of that tooth. But even with the use of ultrasonic, we were able to capture that lateral canal. And because it was a large lateral canal, as much as we were careful, there is some puff on the side, but this is bioceramic, which is a biocompatible material. Obviously, there's no follow-up of the healing, but the paresthesia has all improved. To change the subject, I'm going to show you some crack case. This one needs no innovation to diagnose. Anyone with a naked eye can look at this and know that the tooth has not favorable prognosis and needs extraction. But this is more typical of what we look at. We remove the restorations. There is usually not so much of a deep probing, 6 or 7 millimeter. These are the cases that are mostly happening on the second molars, so the pocket can somewhat be of a pseudo pocket because of the overgrowth of the gingiva in that area. And this is what we see. So we used to illuminate them, we can dye them, but this is where I think among endodontists there is still not a consensus as to what is the turning point. When do you decide to take this tooth out versus try to save it? Because to me, predictability is really a factor that comes very important in decision making. But generally, I think we look to see if this crack stops at the orifice. And like I said, a 6 or 7 millimeter probing, and it's stopping at the orifice. If the patient knows, we usually show them the photograph and chose to save the tooth and move forward, knowing that it probably wouldn't last him as long as the rest of his teeth would. I think that's the option they have. There's been this conversation because mostly in the premolars, we see a lot of premolars these days that have no restoration on them. There's no decay, and then the tooth is cracked. There is something we call fracture necrosis. Those cases are having, if the necrosis of a tooth had happened only due to that fracture line, then the long-term prognosis is a little more questionable. We used to even do this, which is like an exploratory surgery. Back in the days, we would probe. There is a 10 millimeter probing, but the patient's like, what if it's not cracked? And so we would just raise a flap, confirm the diagnosis. This is an interesting case in a sense that when we go to residency, through our residency, they will tell us that we first need to go with the subjective, listen to what the patient says, and then do our clinical examinations and our objectives before we even take a look at the radiographs. Because radiographs are deceiving, but we tend to just look at it and make a decision, especially when you're waiting for the patient to get in there while you have the referral and the radiograph. I'm looking at this and I'm like, okay, this is a regular endo on a number 3, decay to the pulp, necrotic. There is a PA lucency on the mesiobuccal root. I got this. Except when the patient comes in, and unfortunately we couldn't find the clinical photo of this one. When the patient comes in, there is a crack going mesial to distal on this tooth. And here's the CT. It totally changes your treatment planning. Now you go from a root canal to an extraction. There's been a paper out of University of Chicago from Dr. Fayyad's group. He does a lot of research on CT scan, and if I remember right, they were talking about how CT scan in 60% of the time can change or modify the way you treatment plan and your prognosis of the tooth. This is another case. Very nice lady in her 80s came to our office from a general dentist referral. There was a sinus tract. The tooth obviously is an abutment for the bridge. The patient really wants to save the tooth. It kind of looks like it's an apical lesion. We were thinking of retreating versus apical, except we took the CT. So this, yes, there probably is a missed MB2 here, but this is the typical bone loss J shape of the vertical root fracture. The reason we can't probe this tooth is because the bone loss is under the pontic and the bridge. And you can see it in a different view. So at this point, my decision was, I don't think this tooth has a good prognosis, but Dr. Rezai is always the best advocate for all of your patients and all the teeth. He's like, let's try to find that MB2 and see if the sinus tract goes away. Well, I thought that was the end of the story, and I didn't have the rest of it, except I saw him today in the office and he told me, you know what happened? We placed calcium hydroxide, the sinus tract didn't go away, so I decided to do a root resection. So that MB root is gone now, there's bone graft placed in there, and I think the patient's gonna be really happy to have this tooth for a few more years. Sometimes we get that instant gratification that we diagnose a case with a crack. All of us feel really bad for a beautiful root canal like that, that we finally have to decide it's cracked and needs to go, and the oral surgeon actually send a photo of the tooth and we're like, yeah, voila, there's the crack. It, you know, having diagnosed all of those cases with the track really doesn't take it away from us trying. Like that other case I was showing you that Dr. Rezai found MB2, placed calcium hydroxide. Just looking at the J-shaped lesion doesn't mean we're going to have the tooth extracted, especially if the tooth has not been previously root canal treated. This is one that we treated, and 6 months later, you can see how nicely it is healed. This is another interesting diagnosis case. Again, emergency. Most of these cases, obviously, in the past few months for us have been all emergency cases. I took a PA. There is a large palatal swelling, and I'm like, what is this? This is a gentleman in his 50s. So let's do the CT. Upper right corner is the 3D rendering, and you can kind of see there's 1, 2 impacted tooth there. Maybe there's a third one there. I'm gonna look at it from the palatal side. You see that little one down there too. There is an impacted one, the lower premolar there too. Yep, there are 3 separate impacted teeth there. And there is a big swelling there, but that swelling is not tender, it's firm. On clinical exam, number 14 is percussion sensitive and has a delayed reaction to cold. So what I want you to see here is that around the crown of some of these impacted teeth, there is something like a dentigerous cyst also forming, but the emergency was coming from this partially necrotic number 14 here. So we initiated treatment on this one, and then the patient has a referral to see the oral surgeon to evaluate the impacted teeth and the possible cyst in that area. This is another case that came to our office for retreatment. Classic missed MB2. Here's the canal and the completed case. This is an interesting case. Patient has had, came with the radiograph on the left-hand side. Root canal was completed a few weeks ago. Patient still had tenderness. We took a different angle. It looked interesting, like, what is this? Is it ciliar puff? What is this on the side? Is it? So we took a CT, and yes, that's what happened. So it's a perforation, not at the root canal treatment, but at the restorative post-placement. In a case like this, the only approach can be surgical. You raise a flap, you clean out the area, and then you would repair the perforation with bioceramic materials. And honestly, I think these cases usually have pretty good prognosis. This is the before and the after. Let's see what this is. Oh. This one I wasn't able to find the right radiograph, so we're going to skip this one. Am I boring you? So this case, if you were bored, it woke me up in the office. So the patient came with a constant vague pain. And it's always interesting when you get a patient who cannot really describe what kind of pain is it. It's just a nagging, constant pain. And then they have all this dental work done. I mean, upper and lower, large restoration, all restoration. There is a post here with no root canal filling. And you test these teeth, and they are mineralized. You really don't get you don't know if the answers you're getting is a false positive, is a false negative. It's not conclusive, let's put it that way. So we go back to what we do best, which is taking a CT. On the 3D rendering, look at the upper right one. I saw this and I'm like, okay. So on the palatal side, wait for it. There you go. That's the external resorption. There is no way you could have seen it on any angle on that molar. And what the resorptions does is, because they don't really invade the canal and the pulp tissue, you basically don't really get a pulpal classic pain. It's not lingering too cold. Until very late stages of resorption, the tooth never becomes necrotic. It's just this vague nagging pain there. But as you can see, the size of this external lesion is not that big in the classification we have. It's kind of a class 2, you will call it, I guess. So I think this one can easily be repaired surgically. This is an older case, of course. Let me see, we have, should I go to the next one? I'm trying to stop this and go to the next one. All right. So raise a flap and then just repair the surgical external resorption surgically. I'll show you some more resorption cases. You look at the PA and a bite thing on this one. The PA looks pretty normal. The patient still has this nagging pain. There is not much of a restoration or a decay on it, but on the bite thing, you can see this thing on the side of the tooth there. The CT doesn't lie to you, it gives it to you as it is. It's actually a large resorption here. You can see the point of entry is probably somewhere in the buccal. So once you open up this tooth, this is where the canal is, this is where the resorptive area is. And most of these cases, this one was repaired internally. You can see the point of entry, it's still bleeding, so this was an active lesion. Some of these lesions become arrested as time goes by, but this one was an active one. TCA was used to clean up the area. The root canal was completed. It was repaired with BC material, and that's the final fill-up tooth. I'm going to present a few trauma cases and then leave it to Nikki to give you some exciting news on GentleWave. But this was a very nice lady. I think she was in her 70s too. She came to my office with a recent history of trauma. She actually fell and her lower teeth pierced her upper lip. She still had the stitches and all, and then went to the dentist. The general dentist took this radiograph, saw this horizontal root fracture, sent the patient to us. I'm doing my clinical examination. Initially, when I looked at this, I'm like, is it dislocated? But there is no mobility. There is not even much of tenderness on the teeth themselves. I mean, the area is tender because of the soft tissue, but so here we do the CT scan. Just look at this before anything else. What do you see? It's not only that, but this extensive external resorption. You can see it here probably, right there. So what this does tell me is that this is another, it's been a very older history of trauma in this case. This last trauma just was an incidental finding for this horizontal root fracture there. You can see how the external resorption, let me actually bring it back a little here. The external resorption on number 8, look at it here. On the lower right, you can see the extent of external resorption there. And then the fractured one, the reason there is no mobility, it's because it's only on the buccal portion of the tooth. So basically, there is not much to do about this. The horizontal root fracture has healed on its own, and the external resorption is to a point where it cannot be surgically fixed. So we just follow up, and I think she's going to have this teeth for a long time. This was another incidental finding, another trauma case. This was a younger gentleman. He came in, number 7, has quite some mobility. He fell off the bike, and I could see something like a fracture line there, there, but it was a little fuzzy, so we did the CT. Here you can see half of the tooth is gone. This is what we call a replacement resorption. So this gentleman also, and most of the people, they don't remember. If you ask them if they had a history of a trauma 10 years ago, most of them don't even recall. But this gentleman also for sure had a history of a trauma. Replacement resorption is something that happens after external resorption. The body kind of comes into a balance, and it's a sort of repair that the tooth is chewed up and is gone, and the bone just replaces that space. So as you can see, half of this tooth is gone by replacement resorption. But unfortunately, because the structural integrity was compromised because of that replacement resorption, this last blow really caused the fracture, horizontal fracture on the tooth. It's almost pretty close to the crest of the bone, so there is really no way saving this tooth at this point. I'll show you one more case of resorption. This is what we call a Heather say class 4. Really, this doesn't need no innovation. It doesn't need no CT. Anyone looks at this and like, there's nothing to do. And I'm sure you guys are not surprised looking at something like this when you also find this tooth asymptomatic, because like I said, the pulp really remains intact in between the tooth, and all of this happens around the tooth. But the reason this case was important, I want you guys to see it, is a lot of time we chose to take limited local CT scan just to focus on the issue and the problem we're dealing with. But especially in trauma cases and in resorption cases, we have had incidents that like there are multiple teeth involved, so we take a full mouth CT scan. In this one, we were gonna look at this tooth, but the CT showed here, look at the resorption right there, that molar tooth. These are mostly the cases we see after extensive orthodontic treatment. I maybe should not have said that, but the good news is when it gets replaced with bone like this, and the tooth is asymptomatic, I don't think this patient's gonna lose this tooth for a long time. So it's just an observation we have on that number 8. And then on the molar, waiting for it to show the molar one, but the molar one is more coronally, although it is very extensive mesiodistally, so it is an option to surgically try to repair that. I don't know what the patient decided to do in this case. Let's start on the size case. There it is. Okay, one last trauma cases, and that's it. This is a lovely young lady, had a history of trauma, and just look at this CT scan and how extensive the injury was, and how just by having one 3D CT, you can really diagnose all of these fracture lines. And here we go. Upper right side, the buccal of the molars are gone, the crown and the premolars are gone. Here goes the lower left side, the buccal of the molar is gone. And then on the axial view, which is the one that I'm always more interested in, you can see different ways of fractures, like horizontal, on the premolars, on the palatal and buccal side of it, on both sides. And then on the lower, you see a drastic one right there on the canine. That being said, I'm just gonna give it to Nikki for the rest of the presentation.
All right, well, thank you, Yasi. Really great job. I get to finish up with introducing you to the newest paradigm shift in endodontics and talking about the newest technology that we've introduced into our office. Housekeeping thing just about any questions you may have for Yasi so far, or either of us after this presentation. We'll look at the Q&A box at the end of the presentation. So if you're asking something, we're not ignoring you. We'll just get through the presentation and then we can have a discussion about any questions that you might have about any of the cases or any of the technology we have discussed. So to go over, obviously, the goal of endodontics, it's, to prevent and treat periradicular periodontitis. It got pounded in us in dental school and in our residency as endodontists. This was our goal. I think the biggest shift happened during COVID. The general dentist, you had to close during this time. It was sudden. Patients have appointments booked months in advance and they had to be canceled. A lot of times we're getting patients referred from your office who have already been a little triaged and examined. But during this COVID time, we had to extend our focus outside of endo a little bit, sometimes do some extractions, pediatrics, and do a lot more triaging over the phone to determine if it was a real emergency. So obviously this is our goal of as endodontists, but it's also, we became almost the dental emergency room during COVID, and we really wanted to help prevent those patients from going to the ER room and to help them get out of pain during a pandemic. It's just, the worst timing for a patient to have pain and have to risk coming out of the office. But I think everyone was very thankful for us being open and felt safe and made sure we were doing all the protocol and checks that we needed to make sure everyone felt safe during this time. So, the importance of successful endodontics for us, Dr. Yasi, she's been going over all these cases with diagnosis being, I think, the hardest part of our profession. Really, when she said, patients just have a vague pain, knowing where that's coming from, that CT has helped us so much during that part of the appointment for diagnosis and being able to determine where their pain's coming from. Once we determine that, it's a root canal treatment if it is that, but then it's more so the next step is discussing the treatment planning, going through options and risks with the patient, discussing possibly with you as a general dentist or restorative dentist or orthodontist and saying, okay, what's the end goal here? What's the full treatment plan for this patient? Is it restorable or not? And then moving on to the root canal treatment, the knowledge of anatomy and morphology, which I'll get into a little bit more. That's the important part for us during the actual process and making sure that we are treating the entire tooth and the anatomy. Now, thorough debridement and disinfection, that's the part that's gonna make that root canal successful. And having the rotary instruments introduced to us and having that for such a while now, like Dr. Yasi said, we have achieved that part. We want to achieve the chemical success for these teeth. We will go through the micro CTs, but we know all the anatomy that exists in these teeth, the lateral canals, the anastomoses, the connection through all these teeth, and every tooth is different. So that's what keeps our day-to-day job interesting. Every tooth is different for us. And then obturation, of course, that's what we see on the x-ray. That's how we judge ourselves. We're our own worst critic, right? I mean, that's how we determine, oh, this was a success or not. But obviously it's much more than that. And then the coronal restoration, that is, you know, our studies have shown that's actually what determines if it will work long-term, getting the proper crown and restoration on top of that root canal that we have done. So when we're looking into new technology and the GentleWave that I'm going to introduce to you, these are the questions that we ask ourselves. These are the questions that we think about when, is it going to be worth it to us? Is it going to be is it going to be something we want to introduce into our office? So does it make us better clinicians? You know, again, we have so many different file options. But again, what's comfortable in your hand is what's going to work. So with this new GentleWave technology, was it going to improve us as clinicians? Is it going to make us more efficient? Is it going to be safe for the patients and help them feel more comfortable and benefit them if it's going to maybe cost them more to use it? Of course, literature and research. It wouldn't be a dental presentation without some literature to go over to make sure we have the support and the data out there that this really does work. And then, does it raise the bar? Does it make us a more competitive office? Does it make us more competitive for ourselves, just to make it feel like we're improving as clinicians? And then, of course, are we more productive? I mean, that's the honest truth. Does it make sense for the numbers and the day-to-day numbers for the office and the production? So, you know, obviously we had seen this x-ray, Yasi presented it, and she was talking about it. It seemed much more like a process-centered outcome. We got those canals, we found the 5 canals. It's a beautiful root canal. You know, process-centered is if there's a separated instrument, have we been able to successfully remove it? More of the root canal treatment outcome. And then we kind of turned into a disease-centered outcome. This huge radiolucency, obviously in the final X-ray, then looking at a 1-year recall of this, and it has healed. So that makes us feel successful. That is the outcome that we want to see when it's a disease-centered outcome. But I think a lot of medical is shifting towards this patient-centered outcome, and really assessing the patient. Are they comfortable during the treatment? Do they have pain, or are they asymptomatic? When they're asymptomatic, it is a question of, do we need to do treatment? Do we monitor it? Are we going to open Pandora's box and then cause pain to the patient? And that's very much a discussion we need to have with the patient, with the referral dentist possibly. But obviously we want to be as efficient as possible. We want to do a good job, and we want that tooth to last. We want it to survive and stay in the mouth. We've obviously been looking at a lot of CT scans. This is probably the biggest question we get from patients, especially in the Bay Area. Well, I'm really concerned about the radiation dose, and these charts really help when we show them. These are the numbers. You know, you might think we're discussing a CT image here, which is, you know, just a lot more than our dental CT. This is the machine we have, the Carestream 8100, and those full mouth scans, you can see the effective dose of 72 microsieverts. So much more minimal than probably what the patient is thinking. And anytime I've had a patient be a little hesitant, I show them these charts and they, okay, you know, it will be worth it. Let me take the CT and we'll go over it, we'll review it, and you'll see how it's going to save us time for your treatment. So again, this is looking at the medical imaging. It's almost 600 times the risk than our dental image. And over the last, you know, between 2000 and 2005, there was a 200% increase in the chest CTs. And I think a lot of times when patients are going to emergency, it's just immediately take a chest CT, you know, check that. So obviously there's been this huge increase in the medical field for the imaging that they're doing. So here are some of those beautiful micro CT scans that we've seen come out over the last 10, 20 years with all the research. And I think as endodontists, dentists, when we see this, it scares us a little, like, wow, look at all those fins and isthmuses, and how is a rotary instrument going to clean all of that? And we know that the mechanical instrumentation is not going to touch all those walls. It's not going to be able to get into all the anatomy of the root canal system. So we need to, really consider what can we do to do the best possible job of debriding that entire system. Here's an image of the mandibular first molar. Again, just looking at all of that anatomy, multiple portal of exits. When we see this, and I know in dental school we all had extracted teeth that we had to section and practice root canals on. When we looked at the bottom of the roots, we thought, oh my gosh, look at all those exits, and which one is the file going to come out of, right? So again, we know that our files aren't getting into all of these, and we'll get to that question of, is that anatomy important? Is it important that we're not getting a file into it necessarily? Looking at lateral canals, as Yasi was talking about premolars, I think everyone thinks premolars are straightforward, but honestly, I always tell patients, premolars just have the most variation in anatomy, and the CT, it really helps really show all of that for us. So that is that paradigm shift in endo. So Yasi talked about the CT, the rotary, the microscope, digital x-rays. I mean, when those came out, patients were ecstatic that we had digital and the x-ray in the office, right? Now our offices, we have this handheld digital gun, and that's exciting for patients. Wow, that's how you're taking the x-ray, and you're in the op when you're taking it. Well, there's obviously not a radiation concern if you're standing right there when we're taking it. So again, the technology, it benefits us, but it really does make the patient feel more comfortable, and it's making it more efficient for them. So here's the GentleWave console, and we've been trying to send letters to offices to introduce it to you. I'm not sure how much you've seen on it. I see it in journals now all the time. It is really exciting to have this in our office. When I was finishing my residency, this was just being developed, and a literature that I'm going to go over. It was one of my co-residents, and it's exciting to actually be able to have this in the office now, and to know that, okay, it does work. This was real. It wasn't just some gimmick that they were trying to develop at that time. And we're going to go through that. So I know I'm not an engineer. I am a dentist. So I want to play this video for you because I think it does a much better job of explaining the process. And then we're going to go through it. But I think this is just a great introduction to GentleWave and how it works, and so that you can see it used in the office.
Patients want to save their teeth, but they don't want a standard root canal treatment. It's with that in mind we developed the GentleWave procedure, helping you ensure patients a higher standard of cleaning. Unlike standard root canal treatment, which relies on both biomechanical and chemomechanical means to remove infected tissue, the GentleWave procedure effectively cleans and disinfects while conserving precious tooth structure. Simultaneous cleaning of all canals deep into dentinal tubules, isthmi, lateral canals, and other complex anatomy is accomplished through a proprietary technology that leverages multisonic ultracleaning, advanced fluid dynamics, and accelerated chemistry for improved patient outcomes. A few key features that set the GentleWave procedure apart. It all starts in the GentleWave console, where the procedure fluids are optimized through a process known as degassing. This reduces the possibility of apical vapor lock and maximizes tissue dissolution, debridement, and disinfection. Fewer files are used. With the GentleWave procedure, the job of the file is simply to provide an uninterrupted path for a three-dimensional fill. A sealed environment is generated between the tooth and the GentleWave procedure instrument to allow for constant refreshing of degassed procedure fluids and simultaneous evacuation of debris. It's in the procedure instrument that patented multisonic ultra cleaning technology enters the equation. The stream of optimized fluid entering the tooth creates a powerful shear force, which causes hydrodynamic cavitation in the form of a useful cavitation cloud. The implosion of thousands of microbubbles creates an acoustic field of broadband frequencies, which travels through the fluid into the entire root canal system. Gentle vortical flow is induced within the root canal system with a slight negative pressure at the apex. The result, unique to the GentleWave procedure, is unmatched cleaning and disinfection from the crown to the apex. The GentleWave procedure, helping you save more teeth for more patients.
All right, so I should have said that I'm not getting any reimbursement or payment for talking about GentleWave. I do not work for the company. So I do just, I love it. I love the technology and the how it's, again, kind of changed the game for us. So the GentleWave procedure, again, I'm going to kind of be repeating a lot that was in that, but just to go point by point here, it can clean and remove the tissue with minimal instrumentation. Again, we know we're not instrumenting a lot of that anatomy, and the GentleWave can clean it chemically for us. And there's no need to enlarge canals to a specific size anymore. You know, traditionally our research was saying, you know, we had to open to a minimum of size 30 in order to get our irrigation tip down there and to feel like we were doing a good job. Traditionally, we were doing a lot of coronal opening in order to get that irrigation down. And I think years later, we've seen the fractures that have happened because of that. So the more recent focus for endodontists is being conservative, keeping as much of that tooth structure, that dentin, for the tooth as possible to keep just the lifespan for it. So really less is more in the GentleWave, and that can kind of lead to minimizing the instrumentation time for us as well, because we're going to be using the GentleWave to really do the cleaning. That's the important part of it. So again, this is just kind of showing that multisonic energy, those cavitation bubbles, and again, just that's what we're trying to clean, all that anatomy. This is a true tooth. So this is actually this is what they're using in dental schools now, instead of the plastic blocks that we had or extracted molars. They have these 3D renditions of 3D models of actual teeth, and that's what they're used to learn how to do root canal. So I can imagine as a student versus the plastic block with one, you know, single canal in it, seeing this as a student might be a little bit more intimidating. But that's the anatomy that again, that GentleWave is helping us clean. So this is just a little video of the fluid dynamics. This is a dye that was in it. This is a block, but you can see this is that GentleWave going into it, and we can see how fast it's removing that dye from it. So again, that's just the fluid dynamic. It's happening in that too. So as the video talked about, it degasses those fluids for us. We're still using sodium hypochlorite and EDTA. It's degassing it to prevent that vapor bubble from happening. The handpiece is doing all the chemistry for us. We are creating a sealed environment on the tooth with a flowable material that comes with GentleWave to create that platform. This is a picture of the molar. This is a picture of an anterior and how we create a platform and then are using the handpiece on it. And then again, that multisonic energy that's going through there. So here's our exciting literature support. We'll just go through a little bit of it. Just again, so we have the backup and the support of what we're using in our office now. So tissue dissolution in a vital case. This was a study that was done that showed that GentleWave was 8 times greater at tissue dissolution then second fastest device, which was the passive ultrasonic irrigation that we've been using more recently, and then obviously much more than just a standard irrigation needle as well. So the study showed that the tissue dissolution did increase with the increased percentage of sodium hypochlorite. Obviously this was 3-day tested, 0.5%, 3%, and 6%. So obviously that can vary. And then also they found that the increase of temperature was also more effective. They tested 70 degrees Fahrenheit versus 104 degrees Fahrenheit. So that increase of temperature, it was more effective as well. So this is a video that GentleWave came, and this kind of, I think it kind of copies what that study shows. This is in video form, but it was basically in a test tube. They had balloon-fine muscle tissue, and this is just showing, a needle that's going to come down with the irrigation versus this is the GentleWave on the right side. So we're going to see how quickly that tissue can happen. And obviously in a tooth, it's smaller, but it's much more smaller field that it's working in, but just to have a little remake of it. So 20 seconds still looks similar, but we can see what's happening on this right side, and you're not seeing really the air bubbles that we are on the left with the conventional needle, but it's going to be pretty amazing what's going to happen here. As much as we wish we could see those forces, now we're seeing that tissue dissolution happen with the GentleWave. While on the left side, not much has changed. It's about at 1 minute. And there it goes. So that makes us feel good that it is working, especially with those vital cases with the tissue. So here's some histology. Again, wouldn't be a dental lecture without some histology. This is a GentleWave system versus rotary and irrigation versus just no cleaning at all. And this was the one done by one of my co-residents. But it shows that the GentleWave system removes 97% of that tissue debris. So we have this isthmus. So they looked at mesiobuccal and mesiolingual canals of lower mandibular molars, and then the mesiobuccal canals of that maxillary molar. And obviously with fins and isthmus between those canals sometimes, this is a cross-section where, I mean, look how clean that GentleWave is compared to, just traditional rotary and irrigation. The smear layer, this is looking at how the GentleWave just significantly lowered the smear layer versus the standard, which again was rotary and irrigation. And again, the GentleWave, it uses the sodium hypochlorite, it uses distilled water, and then it runs the EDTA cycle at the end with another cycle of distilled water. So just cleaning that complex anatomy, that's kind of the most important thing for us. Being able to, when we get these C-shaped molars, especially those vital cases, we see even after our rotary instrumentation, we can still see some bleeding sometimes from that isthmus in that C-shaped molar. With the GentleWave, it's incredible how clean it is after we run it. And we can just see the difference as far as the removal of that tissue debris. So removal of calcium hydroxide now, our studies, we know with, if we have to do treatment in 2 appointments, we place calcium hydroxide as an inter-appointment medicament. And this showed that calcium hydroxide, it's hard to remove. We think we're removing it just with needle irrigation. But you can see on the left side, even with ultrasonic activation, we still see some calcium hydroxide in the apices. With the GentleWave, it was free of calcium hydroxide, even just with using water within 90 seconds. So if we're doing a 2-appointment treatment for our patient, we might consider doing the GentleWave on the 2nd appointment so that it's going to efficiently remove that calcium hydroxide for us, but then also to get that final clean before we obturate. This is just looking at healing rates. So this being newer, especially in our offices, we don't have the recalls we would love. We don't have those recall x-rays to show you. This is still very much just experience and talking to patients post-op, you know, how was it for you discomfort-wise? Or and most patients have been so happy, you know, feeling like it doesn't even feel like I had a root canal yesterday. This is the study that came out for 12-month healing after root canal treatment using the GentleWave. It was a multi-center study, and it showed that there was an overall 97.3% healing for necrotic, and then also vital cases. So it shows a high success rate for that. So again, this is looking at that console, how it's degassing it, the platform we're building with the handpiece. So this handpiece is a one-time use, as much as we would love to use it multiple times and sterilize it. It is one time. The machine knows if you try to use it again on the same patient. So on the same patient, if you're doing 2 teeth, we have to use 2 handpieces. You can't switch it over to the next 2. And then again, that multisonic. So here's a video courtesy of Dr. Branson. So this is that true tooth that I was talking about, but you can see the needle irrigation versus the GentleWave, and this is that platform with the putty used at the top. And what's interesting with these is that the smaller canals, it actually removes the dye faster than the larger, you know, palatal canal. So again, less is more with this. We don't need to open the canals too much, but the GentleWave, it does run for much longer than a minute, so it's going to be efficient for the entire system if it's a small canal or large canal. So you can start to see the dye moved here, and again, because this is the larger part, it's going to take it a little bit longer. Okay, and then as far as obturating, so you know, this has been newly introduced into our office as well, and I know there's been more discussion about this probably more recently, but it's bioceramic sealers. So MTA, when that was introduced, that was a type of bioceramic. Now we have bioceramic putty from Brasser as well that we're using for apicos, and then now we have bioceramic sealers, so we're actually sealing the root canal, obturating this, and it's simplified for smaller shapes. It's really easy to place this in the canals just with the tips. It's hydrophilic, so it's slight expansion, but it's favorable if there is any kind of moisture in that environment, and it seals really well. And then of course there's an antibacterial effect to it as well. And it's just really easy to use. You don't have to mix anything. So we're starting to love this in the office. Obviously, there's a few negative points, and you know, retreatability has been brought up, and maybe removal of it. I haven't had any issues with that, but again, time sometimes always tells. Okay, so to look at a few cases now that we've used GentleWave with, and again, I don't have recalls for these, but just to go through a few stories. So this is the first case. A patient had presented to his general dentist, this is pre-COVID, stating he had some pain on the lower right. And you know, the first thing when we look at this, we think, oh no, like was that implant placed properly, or you know, we need to take a look at that. The general dentist tested everything, seemed normal, couldn't really determine anything, just had the patient come back in a few months. So a few months later, now it's a little bit more obvious. Okay, we see this vertical radiolucency around this, and that's concerning. Oh no, it's J-shaped. Again, where is that implant? Is that causing anything? So if we look here, that implant's fine. It's not affecting that distal root. It didn't perforate or anything. It was placed nicely. But again, we see this vertical radiolucency down that tube. So we use the GentleWave, and again, patient did great. Patient is feeling great after. There was no buccal probing on this tooth, so I felt like it would have a better prognosis due to that. And I had this patient come back 3 months later for a follow-up, and he's feeling great. Tissue looks great there. There was a sinus tract in that did heal. So excited to see what this looks like long term. But again, these are those, you know, the anatomy that we're talking in different lateral canals and exits that we might see, even a furcal exit possibly. This was a gentleman who had this new bridge placed, came in excruciating pain on this upper right, swelling here. And again, what's nice about the GentleWave is we're able to be really conservative. And when you see this apical split, that is hard to instrument into an obturate and to know, okay, this case is necrotic. We want to make sure this is clean as possible. And with that, we use GentleWave, and patient, you know, calling in post-op, he's doing great and hasn't had any issues with it. We can see all these portal of exits again on the bottom. So again, those premolars, they're fun, especially the second premolars. Here's another premolar case, same thing, just huge radiolucency on the side there. Okay, well, there has to be a lateral there, right? And sure enough, use GentleWave and feel good about that case. This was a really nice elderly lady. She had actually broken off the clinical crown of this number 22, had seen her dentist. He restored it, but knew that it needed a root canal before getting a crown on there. So he's one of those referrals that we have talked to GentleWave a lot about. So he loves it for all of his patients. And we use the GentleWave on this. We see the microscope really helped to find this very calcified canal through it. But we use the GentleWave through it, and we can see that nice anatomy, and we know that's cleaned out. We see this radiolucency on 24, and she came back to take care of that one as well. So here's upper premolar again. We see this huge radiolucency here. This was a new crown that had been placed by his dentist, came back with buccal swelling and pain. And this was the cone fit x-ray. You think, okay, 2 canals, all right, pretty standard, we'll take care of that. We use the GentleWave, and then, you know, again, look at all these portal of exit. And then again, that fin, that isthmus between the two. Here's upper right, patient had excruciating pain. We actually did an IND on this also and helped drain it. Cone fit x-ray, and again, we can see all these different exits, lateral here, a split in the palatal and the distal, and patient's doing great on that one as well. So lower molar, this one not as obvious what's going on here. Brand new crown, beautiful zirconium crown on that tooth, and besides the bite wing, everything looks okay, but it tested necrotic, so got into a few more angles of it, and you know, obviously a CT showed this as well, but did GentleWave, and we got this nice little puff here. Again, that didn't probe, so we have to think this furcal radiolucency, not a fracture, but probably just due to that anatomy. Here's a beautiful case by Dr. Hamid. And we can just see that I believe there was a fracture in this crown. Again, second molar, we see a lot of fractures there. And we can see this beautiful anatomy, really conservative prep, especially when we see those fractures. We want to be as conservative as possible with these teeth. And obviously sending this patient back to his dentist for a crown is really important too. So GentleWave, you know, it virtually eliminates aerosols. I know that's the huge discussion. We've had so many webinars about aerosols in the dental office, how to keep your staff safe, how to keep patients safe. And the GentleWave, it does eliminate that during the treatment. Obviously, we use rubber dam for dental treatment, so that makes us feel safer as clinicians. But it's a sterilized, one-time use instrument. It's minimizing exposure of COVID to everyone in the office. And it just makes us more efficient. It is ideally, during this time, we were trying to do as much one visit treatment as possible so that the patient didn't have to risk coming back for a second appointment. So it maximizes cleaning and disinfection with minimal post-op pain for patients. And I mean, we gotta love that. So advantages, more efficient cleaning and disinfecting, treating and cleaning that complex anatomy, tooth preservation, predictable healing, which hopefully we will see a lot more of our recalls coming over the next few months. Less post-op discomfort for patients, which is that patient-centered outcome that we discussed. That's what's important. And then single visit, especially important during this time. Considerations, obviously case selection, which ones we want to use CBCT on, and then the extra costs that it does add to the patient's treatment. And I think when we show them the console and this technology and we discuss it with them, most of our patients are really excited about it. So here's a sunset in San Francisco. Thank you so much for being with us tonight. We're gonna look at our questions now and go through that. Here's our email, so any questions or anything you don't feel comfortable asking us now, feel free. Obviously, we're here all the time to answer your questions. We're in the office, so feel free to give us a call there too.
And I think the credit, the CE credit will automatically goes to your email from our office manager too.
All right, so let's see, we're gonna start.
How much is the cost per person using GentleWave, and does it decrease the time to complete root canal? So I think currently we charge patients about $150. And yes, it does. I think like you should have answered this question. I just jumped in, but like Nikki explained earlier, to run the machine takes about 10 to 15 minutes. So you would think that adds to the time. But because it takes less time for the prep and the shaping, the mechanical portion basically is a little bit shorter and the chemical portion is a bit longer. So generally our appointments are about that hour and a half that it used to be. A lot of times we get a chance to finish a case in one appointment rather than having to do it in 2 appointments.
Yeah, and I think in the beginning when we introduced GentleWave, there was very much a discussion with the patient. This is new technology. So in the beginning, it maybe took us a little bit longer, but the more we use it, and then the more that we're changing our instrumentation and reduction in that time, that we're doing that, it really does decrease the time to complete the root canal treatment. Okay. Was vertical condensation done? How do you obturate that in shaped fused 2 canals? So yes, sorry, I'm not sure which case you were referring to, but most of our cases are vertical condensation. That's our obturation technique. And maybe in the split, maybe that's what she was asking about.
I think the next question is also about obturation techniques. Mm-hmm. So yeah, in general, we use the warm vertical condensation. Most of the sealers we use have very good flow, and when we have fused canal, I think the way I do it is I usually obturate. I put something in the easier canal, and I obturate the more difficult canal first, and then we just cut it vertically at the split point, pack it, and then go and obturate the second one. Hope we're answering the question.
Yeah. And that bioceramic sealer, again, it flows really nice, like Yossi said. We have different gutta-percha cones. Some are, much skinnier than others, so we can fit multiple cones into a split canal like that, where, that microscope picture you saw with that apical split, we can actually fit 2 cones in there really nicely. So it's just kind of playing around with different options that we have. But yes, warm vertical is overall what we use. And yeah, that was the next question. What do we use in our office? So yeah, warm vertical. Is GentleWave used for initial treatments only, or can it be used in retreatments? And yeah, sorry, I didn't even discuss that. Great question. So it can be used in retreatments, and we love using it in retreatments. Now, GentleWave, it does not remove the gutta-percha for us, and yes, hopefully that's a future for us. That would be really nice too. But you still have to do the initial part of the retreatment, obviously, accessing, finding any missed canals, removing gutta-percha carriers, whatever it is, and then run the GentleWave. And it's kind of amazing how before sometimes doing a retreatment, it still looks pretty dirty, but once you run that GentleWave, it looks really clean. So those are really nice for retreatments to be able to do them in one appointment as well.
I mean, remember, again, the mechanical portion of it, we still have to do it ourselves.
Right.
It's the chemical part that'll take care of it.
Yeah. And you still have to find the canal.
Yes.
So you still have to do that part to it. So those can still be tricky.
I don't think that's the question, but someone was saying that they can't hear anything. I hope they have fixed that problem by now because it was a long time ago.
Oh, that's a long time ago. Okay. Well, thank you. Any more questions, everyone?
Well, thanks for your time and for being such an integral part of our practice. The education really starts in your practice, letting your patients know what technology are available and what it can offer them, and then trusting us to treat your patient in the most efficient, successful, predictable way.
All right.
Happy Thursday.
Thank you.
Bye.
Have a good evening.
Cheers.